Gerhard, as I expected, you didn't disappoint at all, but I want to challenge you afterwards a little bit and trying to do some nonsense here. I would like to invite Dr. Restellini, Sophie Restellini, who came all the way from Geneva across the Rideau de Rösti. She has trained in Geneva, she's habilitated there, and she was in McGill for a long time, and now she opened up her own IBD center, so she probably wants to gain some ideas from us, be my guest. And Dr. Pascal Juillerat, aussi moitié Rideau de Rösti. He was long-term at the university in Bern, in the Insel. He's now also in private practice in Lausanne, and he spent time in Harvard, so we get some Harvard spirit here. So now, shoot, you have questions for Gerhard?
So my first question, Gerhard, is so you nicely, and thank you for this very good overview. You showed nicely that this patient you mentioned, and that's the most interesting, is practice and the case we have with this situation. She was partially responding to all both treatment, and I think it's probably the best or most intelligent way to plan the combination therapy is thinking what is going on with the patient, and you decided to combine, not to increase the dose both, but just to combine. There are other way you would do this combination, other kind of indication. Which situation do you still think in your practice with your patient?
So in fact, we have a number of patients on combination therapy, and they are all patients that initially had a response or a partial response to one of the biologics. So we really try to choose combination therapy based on the patient's history, right? When they had a partial response to infliximab and a partial response to ustekinumab, I think this makes sense to combine it, because you know they have a partial response, but they have immune cells that can escape this response, and you try to capture them with the combination. And I have to say that most insurances accept that, because at the end, for them, it's cheaper than to have those highly intensified therapies where you have almost weekly injections of whatsoever, right?
But you gave both drugs every 8 weeks. You didn't do eight. I mean, that you get Q16, the two drugs. Did you try that? So that you give Vedo every 16 and in between every 16 the TNF?
No, we didn't do that. No, she had it. She had both every 8 weeks. And by the way, to give you an update on this patient, in the meantime, after 3 years of remission, she stopped the infliximab and she's on Vedo mono, and it works now again.
I mean, there's questions from everyone. Everybody can shout it. There's some microphones around. Yeah.
Hello, I'm Gerhard Rogler, I'm abdominal surgeon with private practice in Zurich. Actually, my question is there also a future for combining fecal microbiota transplantation and immunosuppression, meaning modifying the trigger and modifying the immune response?
That's exactly beyond, you know, that's where I wanted to go to. Thank you, from a surgeon. I'm impressed.
Yeah.
Gerhard.
Yeah. Well, I think yes, but not fecal transplant, because, you know, Séverine Vermeer wanted to find a super donor, and she did a selection according to all the criteria that would select a good fecal donor, and the result was nothing. And we know that that combinations of 7 donors that you repeat like over 8 weeks, 5 times a week, they have an efficacy of steroid-free clinical remission of about 22% over placebo. So it works, but we cannot identify the donor that works. And this is a major problem, to my opinion, and so we need to have more selected and sort of artificial FMTs. But here I'm biased.
But you know, at UEGW, and you know, it was the hype of FMTs, fecal microbiome transplant, you know, do some crap. And then, you know, from above and from below, and then nobody knew, then it was a problem. And then sort of it subsided, and now, but it's been revived a little bit, you know, in UGW, you know, and they now say, you really have to give it from the top. So but you don't need to swallow it. It's maybe capsules, you know, frozen, encapsulated crap.
Yeah.
So, I mean, you know, I think I'm very disappointed about Vega.
Yeah.
We had great hopes. We do double, great. Now we're really powerful. And you know what you get? Maybe, I think the patient selection, that's what Pascal was alluding to. I think that's our problem. We don't know what's going on. We need to be able to identify markers, whatever, which patient needs what. And we're so bad at it. We're like blindfolded. We just start something like alchemists in the past. So how do you want to, you know, are there any molecular, would there be biopsies or expression profiles or anything that would help us to say, oh, Mr. Miller takes that and Ms. Fisher that?
Yeah. I mean, I would pass on this question to the two experts. I'm not aware of any predictive marker that would really help to decide on therapy at the moment.
No, I don't think we have any predictive markers. We're still relying on our clinical impression and few biomarkers, but the predictive markers are still very disappointed.
No, Gary, I want to challenge you about nonsense. You said upfront combination therapy is nonsense. Is it? I mean, we're entering the same discussion we've had over 10 years ago. Remember? Top down, step up. The nice pyramids, then turn it around. What shall we do? Be more towards top down, right? From the original thing. You use a little, but okay, in a very accelerated step up. That's almost a top down, okay? But you don't want to wait, because we know if you wait years and partially treat, you end up with these ridiculous patients. You can do whatever you want. It doesn't work. But seriously, I'm not joking, is because when you see the Vega trial, those are all patients, complicated patients. Patients been on, what's the mean duration of disease? Probably 10 years, 8 years, something like that. So my question is, are we too late with the combination? That obviously not up front, but shouldn't we still trying to identify the patient, not the molecular markers, but like I said, basic clinician like we are, to find the patients who are particularly will do well, you know, and that we're going to be a little bit tougher on them early on.
So my vision of the Vega trial also is at some point when we do clinical practice and your patient is on an induction treatment, is not doing so well, so you do like small bridge with steroids and you try stuff and add-on therapy and to make it stable. So we do already combination a lot. So why not doing real combination as it is in this publication? And you really see that golimumab had some effect, but we all used golimumab and had the feeling this drug is a good anti-TNF, but sometimes not enough for the patients, and we have always to stay on the higher level with this drug when we use it for ulcerative colitis. So why not combining and just getting this additional effect that you see really on the curve? There is some point where the effect of golimumab is going down is exactly at the end of the induction when you have the additional effect of the other one. And then using this kind of two combination, as long as we really need it, as Gerhard did with his patient, so using the combination and then going back to the one you decide would be the maintenance drug ideal, and you follow up this way. And if needed, you come back with the other drug also, because it's better for the induction or to re-induce the response. So we use it as a kind of steroids in addition, as we did sometime with the steroids. And when you do it in a short period of time, reasonably, correctly, could be more or less safe and not a big risk of infection if the patient needs it, but it's your interpretation at the end.
I mean, the JAK inhibitors, Len, would be an ideal drug. It's a pop a pill, works short, effective, quick, fast, instead of steroid. I mean, no, could be an option. If some JAKs instead of steroid.
unfortunately, we had this drug warning from EMA on all JAK inhibitors. We are from November, I think 11th, we are now warned to use it in all patients above 65 and patients with tumor risk. Now, if we would take that seriously, we couldn't use it in ulcerative colitis anymore because all our patients have an increased risk, right? So there are some issues going on. I think the Vega study is a game changer indeed, because what we see is like remission in monotherapy, 25% remission with combo, at least until week 12 is 50%. So when we translate it in number needed to treat, we end up with a number needed to treat of 4 for steroid-free remission. That's much better than combining thiopurines and infliximab. So combining anti-TNF and P19 antibodies seems to be really a very, very interesting pathway. I don't think that's specific for golimumab and guselkumab. Mm-hmm. We will have like 3 or 4 anti-P19. We have already 4 anti-TNF. So this combination seems to be really promising also with respect to the basic research data where we see that we have those 2 pathways that are used to bypass always the other. I think that's one of the really, really game changers that we will see.
Ask a different question completely. I was surprised about the immune response data on the vaccination, COVID vaccination, and not part of it. I'm surprised that with the with the JAKs, don't have it. It's not so much diminished. I would have predicted otherwise. Yeah.
So for monotherapy, there was not a big reduction. There was a reduction for anti-TNFs in response, and in the combo therapy, there was a clear, definite reduction in response.
But what he really emphasized, and what we all forget, and I plead guilty, is it's so cumbersome to get all those vaccination records, because we in Switzerland don't have an electronic medical record. It's bad. So, like in the Scandinavian countries and so on, we need to vaccinate our patients, should do like shingles and so on, everyone who's in practice.
I have one question for you all. So we were talking a lot of combination of biologics. Now I would just like to go back to the more standard combination as azathioprine infliximab and update a bit. I know a little bit what we are doing in Switzerland, but just have your point of view. You still combine a lot azathioprine with infliximab, in which patients and which dosage mostly, because there is a lot of data going out showing that. I don't know who would like to give the answer.
I have to confess, I don't do that many combinations with thiopurine anymore, because the benefit of thiopurine is that you want to increase the level of the drug. And now that we have the therapeutic drug monitoring, what I try to do is to be a little bit more proactive and to adapt and increase the infliximab dosage quite early, and then you can keep your patient on the monotherapy. So I tend usually to try to optimize the infliximab more than combining treatment, and also you don't have those problem of compliance with the second drug. So that's that we have a good data postdoc from Sonic that patients who had the highest level of infliximab were doing better, respective if it was a combination therapy or a monotherapy.
Yeah, we lost a lot of patients due to the adverse events of the thiopurines, actually. Yeah.
So I think people had enough of drugs, and we're going to go on to like the real endoscopy and the real GI stuff. But Gerhard, thank you very much again, and we'll talk when we use 3 or 4 drugs and still don't get there, and we need to get new mechanisms, new ideas. And the microbiome is not out, okay? So we'll broaden the horizon. You do all sorts of stuff, okay?
Yeah, I'm sure you all remembered my disclosure slide, and you saw that that I'm a co-founder and scientific advisor of a microbiota company. And actually, I think that's really one aspect, but I think what we have to do also in microbiota therapy, we have to come to defined therapies where we know all the components and where we can do a treatment with defined components in a defined way where we know what the effect to expect, and not something where we just take poop and put it into the gut, and this is not
Okay. On this word, I think that's a good way to end this GI session. Okay, thank you. Okay.
Thank you.